Good morning, all of you. Sorry for the sending the link late. Dr. Satish, the head and consultant in Apollo Hospital, Secunderabad, is going to talk on syndromic approach of tropical infections in ICU. Dr. Satish, please, over to you.
అన్న ఒకసారి స్క్రీన్ షేర్ చేస్తున్నా.
డేవిడ్, సిండ్రోమిక్ అప్రోచ్ ఓన్లీ ట్రాపికల్ లో ఉంటుందా, మామూలుగా వేరే దేంట్లో కూడా ఉంటుందా?
సార్
ట్రాపికల్ సిండ్రోమిక్ అప్రోచ్. గుడ్ మార్నింగ్ సార్. సిండ్రోమిక్ అప్రోచ్ అన్నవాడు ఓన్లీ ట్రాపికల్ ఫీవర్స్ లో ఉంటుందా, మిగిలిన దాంట్లో కూడా ఉంటుందా అని అడుగుతున్నాను.
అంటే whenever they have any disease is presenting with more than 3 or more than 2 systems involvement in 2 different presentations, we can call it as syndrome. సార్ డేవిడ్ స్క్రీన్ కనిపిస్తుందా?
Yes sir.
Okay sir. Good morning all. Good morning Mohan sir. Actually this class got postponed twice and there is little bit lag. We lost interest. Okay, anyway, we are again trying to kindly bear with me. There is it's late for 10 minutes. So today we are going to talk about that what we were discussing previously in the 2 previous classes regarding the tropical fevers. So in this topic, I'm going to give a nutshell idea about that various presentations of commonly occurring tropical diseases, particularly the India, where we are all called as one of the tropical country. Case wise, it's a 33 years old male. Fever on 16th of September. First routine tests were done on a OP basis. Malaria negative, typhoid negative, TLC is 6,500, platelets more than 2 lakhs, dengue NS1 negative. Took over-the-counter medication, some paracetamol and unknown some antibiotics like Fixin, Visplone, something like given by an RMP. Patient has no improvement till 19th, so it's almost 3 days. So medication changed to, he has gone to the qualified guy, then he has given Monosef, Defcort and Chiroflam, which is another masala medicine. There is no improvement. There is follow-up investigations, drop in the platelets to 90,000. Then he got admitted to our hospital on 21st. In a local hospital where he was given NL6, again steroids and some B12 supportive care. Platelets further dropped to 40,000. And he been shifted to Apollo Hospital on 23rd. So almost 16th to 23rd, 5 days. Hello? Any difficulty, sir? Any difficulty?
No, sir. Good morning, sir. No, just now sound involved.
Good morning, Srinivas, sir. Right. So in these 7 days, fever continued 7 days, and maximum we have seen 104 degrees. Rash still present on the body. There is a drop in the platelets from the day 1 to day 7. It is from more than 1.5 lakhs to 40,000. No significant.
Sir. Very sorry. Konjam oka brief ga cheppara idi em case?
Presentation fever from 16th of September. Local treatment for 2 days. Institutional treatment for another 2. Doctor treatment for 2 days. Institutional treatment for another 2 days. Found that there is a rash, fever, and drop in platelets. Dengue NS1 negative. Shifted to Apollo.
So fever enrolled, sir?
Sir?
Fever enrolled? Fever 4 days now.
From 16th, the patient came to my hospital on 23rd.
Okay. Sir. Okay, sir.
So we found that this patient platelets came down to 40,000. Still fever spikes are there, touching once in a day up to 103 to 104.
Yes.
And there was a significant rash over the body.
Okay.
So
రాష్ ఎట్లా ఉంది సార్?
చూపిస్తాను సార్, ఫోటోలో ఉన్నాయి.
రైట్ సార్.
No significant travel history or any insect bite. In Apollo investigations at admission, we sent all the pan cultures, fever workup, whatever that possible, like chikungunya, lepto, Wilfelix, MP, viral, COVID profile, everything being sent, coagulation profile, complete urine examinations, everything related to fever, and we have looked into the even ultrasound abdomen. We found that there is an altered LFT, elevated SGOT, SGPT with normal bilirubin, chikungunya, dengue, IgM, IgG negative, MP negative, scrub negative, LDH is 600, procalc is 2.3, CRP is 180, D-dimer is 1000 plus, ferritin 1000 plus, TLC 1600, platelet count 1 lakh, COVID negative, and chest CT scan chest is also negative. He was given meropenem, teicoplanin, dermatologist opinion, medical guest opinion, Coombs test done, ANA profile done. This was the rash, sir. Back rash also on the palmar aspects of the hand. So whatever that is possible, we have sent related to the tropical fevers.
ఒకసారి చూపించిన ఫోటో మళ్ళీ.
Sir, this is the.
Thank you.
So there is a healing rash and a new eruptions of rash are also. The idea of putting this thing is the dark patches here are the healing rashes, but intermittently you can see the fresh crop of rashes that is in the bright red color or water pinkish color. Okay, so this rash distribution was all over the body, including back, thighs, crore and all this, including, but this is one specific thing. Most of the rashes, they don't involve the palmar aspects of the hands, but this patient has rash over the palmar aspect of the hand also. Okay, so we all the tests are negative, dengue negative, scrub negative, lepto negative. We continued the same treatment. So I'll just follow it up. So this is the introduction to my topic. The cases will be presenting like this, but still we may not get any early diagnosis, but we are beating around the bush by giving high antibiotic support and ICU care. So infections that principally occur, parasitic, viral, bacterial and fungal infections in the tropical areas. Tropical areas, they usually have that fever, rash, plus or minus drop in the BP, thrombocytopenia. There is altered LFT, there may be altered renal functions. So this is like it is not pertinent to any single organ, it is a multi-organ involvement, but we don't find anything specific to that particular organ. X-ray may not be showing any patch. So we need to look into such things. And whatever the possible diagnostic modalities, we have to pinpoint the diagnosis. So having these sort of problems, we need to have a comprehensive approach to tackle such patients. Tropical areas means in between the two tropics, Tropic of Cancer and Capricorn. So in that area around the either side of the equator, these are the, so India is one of the country falls in that area. So this is the environment is the main culprit here. So high rainfall followed by forest area, and there is a possibility of like insects dwelling areas, and usually after the monsoon we'll get such type of diseases. So acquired zoonotic diseases like leptospira, Japanese encephalitis, brucellosis and Q fever also in the list. And second thing is the poor sanitation and poor patient hygienic conditions, waterlogging, consumption of contaminated water. All these things leads to like communicable diseases, typhoid, amoebiasis, viral hepatitis, travelers diarrhea, neurocysticercosis. There is one INDICAP study. So it studied about the tropical fevers in India and ICU care. The mortality owing to the tropical infections was significant. It is around 7. And this is one specific study done by an Indian, Singhi et al. Conducted an observational study who requires ICU admission with a tropical fever. Dengue patients 23%, most common tropical fever, scrub typhus, then encephalitis, meningitis. Next comes malaria, leptospira, viral hepatitis, typhoid. So order of occurrence, Dengue is the highest occurrence. In this, 18.4% patients died. 4.4% patients had some disability. The important finding in the study was the mortality was higher in the patient with unclear etiology. Unless we come to a diagnosis, giving you like broad spectrum antibiotics and all these things which covers may not be a correct way. We need to have a diagnosis, but as per the study, they said that undiagnosed patients' mortality is more. The independent predictors in such patients are need for an invasive mechanical ventilation, presence of multi-organ failure at admission, and SOFA score on the day one. These are all the independent predictors of the mortality. So there is a separate one article. It's a neglected tropical disease among the associations of the Southeast Asian nations. It's an overview and update. So sepsis guidelines always there. Mostly the participants are from the West European countries. So the prevalence of tropical fevers in European countries is relatively less when compared to our. So those diseases are not there. So the each disease-wise contribution to the sepsis and septic shock, it's completely ignored in our sepsis guidelines. Actually, if you go into the etiology of the sepsis as per the 2021 or previously 2016 guidelines, the place for this typhoid fever, dengue fever, these things are not there in that. They always talk about sepsis because of pneumonia, sepsis because of UTI, sepsis because of meningitis or intra-abdominal infections, skin and soft tissues. They didn't give importance to tropical fevers in the surviving sepsis guidelines. The malarial burden in India, trends are changing for the last 20 years. So initially, as per this Karnad and Krishnan study, 3,000 patients are having a severe malaria in the public hospital in Mumbai from 1999 to 2002. In this, most of the patients are falciparum infections. 10% are mixed infections, but 90% are falciparum. Then at that time, Vivax malaria is very, very rare. Later on, slowly it being shifted. And as per that recent 2010-2011, that Nadkar and et al. They studied, there are 711 patients they studied, and out of which 69% were due to Vivax. So there is a drift of the bug, that is falciparum to Vivax is happening. So mortality in the severe Vivax malaria is 9%, whereas the falciparum malaria is 16%. So these are the whole list of tropical fevers: malaria, typhoid, dengue, lepto, chikungunya, viral hepatitis, typhus, tuberculosis, brucellosis, lizard, amoebiasis, visceral leishmaniasis, parasitic hyperinfestation, strongyloidosis. So in this, whatever that is, you can see that whatever that is given in the almost yellow color or golden yellow color are very common. Most common is malaria, then comes typhoid, leptospirosis, and rarely we come across melioidosis, Pseudomonas pseudomylia, herbal called Cepaci. So we need to approach to these patients is we need to have a detailed medical history. Patient should be able to elicit any underlying condition associated with increased risk of infection, such as immunocompromised states like diabetes, neoplastic conditions, HIV infections, previously splenectomized, or any patient who is pregnant. And we need to look into any recent insect bites, arthropod bites, sexual exposure, occupational risk, animal contact, immunization, and drug history also need to be included in our history. How to like get the information. Then duration of illness, like is it an acute 1 to 2 days or is it a chronic problem, and the pattern of fever and the geographical, any recent travel to any area which is endemic. These things we need to look into the history. Scrub typhus is most common in the rural areas or semi-urban areas, used to be, but now slowly it is also people, because of the migration and easy transport facilities. Even urban slums are also we are able to see this scrub typhus. And second thing is post monsoon and patient post floods. We need to, like, if any patient comes to us, we need to think of these sort of diseases. The interval between the travel and onset, that is also one of the important finding in the history. Travel to that villages for a festival or something, coming back to the city, and again they are having a fever. So these are all because they simply say that if you ask where do you stay, I stay in Hyderabad. But if you ask really recent history, anyone who went to our native place, or we spent 4 or 5 days there, then came here. So those sort of histories we should not miss. And particular activities like any going to some recreational, any resort, spending good time in the swimming pools and lakes, local some wells. These things are also a good habitat for leptospirosis and schistosomiasis. Places where there is less rainfall, but may not have the water flooding and rainfall is not actively present in any area, like leptospirea is rare. And drinking of unclear water leads to some diseases like hepatitis A or E and enteric fever, non-enteric salmonellosis and cholera. Uncooked food is also a parasitic infestations. So syndromes, we need to classify these disorders into acute undifferentiated fever, a fever with rash and thrombocytopenia, fever with ARDS, acute febrile encephalopathy, fever with multi-organ dysfunction. Coming back, acute undifferentiated fever, patient with acute onset of fever without any localizing signs and symptoms for less than 2 weeks, malaria, dengue, lepto, scrub typhus. Fever with rash and thrombocytopenia, acute onset fever along with the transient skin rash and drop in the platelets less than 1 lakh, dengue, lepto, measles, rickets cell infections, meningococcal infections, malaria. Fever with ARDS, acute onset of fever with respiratory distress, PO to FiO2 ratio is less than 200. Again, it is scrub typhus, falciparum malaria, hantavirus, melioidosis, community acquired pneumonia. Acute febrile encephalopathy, acute encephalitic syndromes with altered mental status, fever, 7 days of onset of the fever, like it's an encephalitis-like picture, meningitis-like picture, or encephalopathy itself. Encephalitis, again, this is the list. Fever with multi-organ dysfunctions, bacterial sepsis, malaria, scrub typhus, lepto. And one thing is we need to the last should be, we should consider macrophage activating symptoms. The disease groups, this is like it's a mnemonic, the repetition. Then this the predominance of one feature usually points to the diagnosis. Severe thrombocytopenia suggests dengue and malaria. Rash suggests of rickets cell infection. Arthritis to chikungunya. Jaundice, lepto and malaria. Subconjunctival hemorrhages, leptospirosis. These are the clinical, particularly we can attribute to that disease. Approach to the fevers, history, physical examination, basic test and advanced test. History is very important. It's an algorithm. Patient presenting with diarrhea and vomiting. It can be watery diarrhea, it can be bloody diarrhea, it can be chronic diarrhea. Watery diarrhea, again, these are the diseases. Bloody diarrhea, Shigella, E. coli, enterohemorrhagic E. coli, amoebic dysentery. Chronic diarrheas, again, amoebiasis, tuberculosis, strongyloids. Abdominal pain, patient may have a peritonitis like the picture in typhoid perforation and ruptured amoebic ulcers, liver abscess or ruptured amoebic liver abscess. Other tropical fever presenting as acute abdomen can be amoebic liver abscess, splenic rupture, biliary colic, intestinal obstruction or volvulus, acute salpingitis and severe GA. Jaundice, all these diseases will have an altered LFT and there is a rise in the bilirubin, starting from the direct liver involving diseases like viral hepatitis. Then comes leptospirosis, yellow fever, amoebic liver abscess, malaria, hemolytic uremic syndrome. Cough dyspnea, amoebic lung abscess, pulmonary tuberculosis, ARDS because of the scrub typhus, lepto and malaria. Diffuse intra-alveolar hemorrhages in dengue, lepto and hemorrhagic fevers. Patient with CNS presentations, most febrile illnesses, especially malaria, typhoid and dengue fever are accompanied with headache. So, same picture. Then incubation period wise, less than 10 days, 1 to 4 weeks, more than 1 month and variable incubation periods. Looking at this onset of fever and recent history of travel and any history of insect bite, and after that how many days happen to get the first symptom like a fever or rash, we need to, if we can find out this lapse happened, that could be like incubation period, we may have some suggestion towards that disease. Duration based approach, any patient who presented to the fever within 7 days of some insult like travel or insect bite, it could be arboviral infections, malaria. If it is between 7 to 14 days, it is typhoid, scrub typhus, leptospirosis. If more than 14 days, it's like brucellosis, melioidosis, leishmaniasis. skin rash, travel history, occupational history, exposure to the contaminated water source may be due to leptospirosis, seasonal variations, animal exposure, tick bite. And we need to look into the previous antibiotic or drug history. Patient is not improving with a course of cephalosporins more than 5 days, doxycycline more than 3 days, azithromycin more than 5 days. Usually rules out such diseases. Patient who has already given these medications, still patient is not getting cleared of his fever, then we need to understand that they are missing something. Findings and examination, whole from top to bottom, leptospirosis, we need to look into some eye changes will be there, conjunctival changes. Then similarly, head to toe examination need to be done. If the patient is having any eschar, we need, it's a pinpoint diagnosis, it is scrub typhus. And patient is having jaundice, we have to look for leptoscrub and viral hepatitis, hepatomegaly, splenomegaly. So this head to toe examination definitely will give us some extra information. So what are the investigations to be done? Complete blood picture. We need to look into leukopenia or anemia, thrombocytopenia, hemoconcentration, eosinophilia. Then comes serum electrolytes and liver function test. Coagulation profile should be done. Peripheral blood smear may show causative parasite in malaria or trypanosomiasis. Rapid diagnostic testing to detect the pathogen-specific antigen. That could be for NS1 for dengue parasite, LDS for parasite, LDS for falciparum malaria and vivax malaria. Blood cultures confirms salmonella, melioidosis, and bacterial infections. So individual disease, again, it may be a repetition for you. The headache, fever is a characteristic saddleback pattern. Malaria, polyarthralgia, and myalgia will be there. Abdominal pain, retroorbital pain, severe body pains, headache, rash spreading centrifugally, and there is petechiae, ecchymosis, and bleeding manifestations are seen. And NS1 positive within 1 to 2 days, and IgG, IgM positive only after 5th day. So dengue, when the patient requires ICU care, patient who is in extreme shock, fluid accumulation with respiratory distress, severe bleeding, impaired consciousness, liver failure, and myocarditis. And I want to add some more things here. Severe rhabdomyolysis. I have seen 2 patients in this week. Patient presented to me with IgM positive. All other investigations are negative, and the CPK is more than 3 lakhs 2 patients. Both the patients' presentation is the same. So that need to be added here. Elevated, unexplained elevation of CPK. Scrub typhus, eschar. Patient particularly in the hilly area, foothills of the Himalayas. Fever with relative bradycardia, headache and apathy. Maculopapular rash. It can lead to pneumonia, ARDS, myocarditis. IgM ELISA is most sensitive. Wheel Felix is a screening test. Indirect fluorescent antibody is a gold standard. So this is the eschar. It's a typical of scrub typhus. Patient requiring ICU in a scrub typhus is impaired consciousness, ARDS, renal dysfunction, DIC. So the treatment is doxycycline 100 milligrams twice a day. Leptospirosis, early findings, non-specific flu-like symptoms, then relapsing or remittent fever. Later immune phase will involve all the organs like hepatorenal involvement, myocarditis. Hello? So diagnosis is elevated CPK is one of the important finding. If the CPK elevated, there is a high probability of leptospira, maybe our diagnosis. There is elevated transaminases. Serology test with microscopic agglutination is a gold standard. PCR test for leptospira should be considerable, but I don't know whether they are doing it or not. IgM antibody may be false positive with enteric fever and any other tropical infection. There is a possibility IgM can be positive, which are false positives. This is the eye changes in the leptospira, conjunctival subvision, jaundice, and subconjunctival hemorrhages. Patient requiring ICU, similar multi-organ involvement. Treatment of choice is crystalline penicillin or any cephalosporins. Malaria, we all know, I'm not going into the details. We need to look for a thick smear and thin smear and a quantitative buffy coat, then we have to examine it. Particularly antigen test, immunochromatographic test based on the antibody. Sensitivity is more than 95%. And one thing I want to highlight here is do not start anti-malarials as per the new guidelines that are existing now. Try to find out the like what type of parasite it is. Then only start treatment. Malaria, previously in India, we used to call any fever can be malaria. In my childhood, no. All the walls, government, state government, municipality people come and put a stencil like Jorama, malaria kavachu immediately. But now it is not correct. All fevers are not malaria. It is now we have to identify because the resistance pattern is now worsening. This is the thing which supports my statement. Clinical malaria is not recognized medical entity and has resulted in a great overdiagnosis of malaria infection and underdiagnosis of other causes of fever. So malaria patient requiring ICU, multi-organ involvement, seizures, impaired consciousness, shock, severe bleeding, respiratory distress. Enteric fever, relatively less like incidence of presentations. Melioidosis, rarely people from northeast and people from the like patient whose fever is not subsiding even after 14 days, 21 days. Then there is multiple lymph node involvement and there is multiple abscess in the body, splenic abscess, mesenteric abscess. So maybe it is melioidosis. Pseudomonas pseudomelia is the bug. So treatment of choice is either cephalosporins or carbapenems. First of all, we have to start the treatment, airway, breathing and circulation. This is how we have to manage such patients. All the tests should be like performed. Try to restrict our invasive monitoring because we don't know the patient might be having a thrombocytopenia, coagulopathy. So initially, wait for aggressive invasive monitorings. Get the investigations, basic investigation done and rule out. Look for the PTNR, thrombocytopenia, then replace the products. Then only we can go for invasive hemodynamic monitoring. Blood components to be given. Isotonic fluid should be given. Maintain a hematocrit less than 33. Same antibiotics, cold sponging. Paracetamol is the drug of choice to decrease the temperature. And investigations possible. All over the possible screening tests should be done. There is no role of empirical chloroquine or artesunate as indiscriminate use of may potential drug resistance we discussed. Better to initiate with a doxycycline and ceftriaxone combination which causes many of these diseases. It's all syndromic approach. Specific medications for malaria is IV artesunate and IV third generation cephalosporins for leptospira and typhoid, paratyphoid, and bacterial meningitis. IV doxycycline covers scrub typhus, rickettsial, and Q fever. Also, again, second line of management in leptospirosis. Who recommends doxycycline plus artesunate for therapy of falciparum malaria? Azithromycin is an alternative to doxycycline in children and pregnants. And if there is an influenza epidemic, better to be like oseltamivir also should be included in the list of medications to be given. Melioidosis is very common, like northeast states. Ceftazidime or meropenem are the drug of choice. Take-home message: a systematic syndromic approach is important to make a diagnosis of such infections. Proper history taking, recent travel, insect or mosquito bite. We need to be like we have to probe these things. Talk to the family, talk to the patient. Then onset, nature of the illness, duration of the illness, and duration from the exposure to the insult and having first symptom, and dietary habits, recreational activities during the travel, any swimming, exposure to the forest area, having an insect bite. Always give some attention to the incubation period, consider it. Primary stabilization, airway breathing, circulation, fluid resuscitation is important. Temporary treatment is often initiated in admission. Combination of artesunate, doxycycline for malaria, ceftriaxone for leptospirosis, doxycycline for scrub typhus, azithromycin is an alternative to doxycycline which covers 5 of these diseases. And if you're in the patient from epidemic area of like swine flu, we need to add oseltamivir. Treatment should be tailored as early as possible to the specific condition once the diagnosis is confirmed. Diagnosis most viral infections by nucleic acid reverse transcriptase polymerase chain reaction. Positive only in the initial stage of the illness. Late stage demonstrate IgG, IgM antibodies. And usually they are positive after the end of the first week or in the second week. Some patients, we find that there is a 4-fold increase of the specific IgG during the convalescent phase. So IgG is present means patient got infected, may be recovering. IgM is for active disease. Some areas where we may not, like in the duration when we are taking the test, sometimes the screening test may not be positive because we crossed the time, and the antibody test may not be positive because we are not still gone into the antibody generation phase. So usually dengue will come across such problems. Dengue NS1 will be positive only in the first 2 days or 3 days, and IgM positive only after 6th day. So in between, if you do a test on 4th day or 5th day, we may not get any, even NS1 will be negative and IgM also will be negative, and will be misled because of that. Any fever lasting for more than 7 days, dengue viral infections are less likely. Thank you, and open for discussion and any expert opinions. Welcome.
Thanks, Anna. Thank you very much for the very extensive coverage of all the syndromes. What is your final diagnosis of your case?
Anna, recorded message appudu eppudu ide chepto
ఏం బానే ఉంది కదా, చెప్పాలి తప్పు.
Mohan sir and Srinivas sir, all the seniors, Srinivas from Vizag, Rani madam.
What is your diagnosis, your patient diagnosis?
Yeah, my patient diagnosis is we have done, so sorry, I forgot to tell you. My patient, we have done to a 15 days fever, we have done continued meropenem, continued torgocid, skin biopsy taken. Skin biopsy is only inflammatory reaction. And after starting doxy in my hospital, after admission to my hospital on 5th day, patient temperature came down, and I think it got responded to doxycycline, and all the investigations are negative. Scrub negative, lepto negative. There is nothing like malaria, typhoid, no. So finally, ID specialist told scrub wheel felix negative, and antigen also for scrub typhus negative. So he has given that we don't have an investigation positive to taste something, but most probably he has given a history that he went to suburbs of Bangalore to attend a funeral, where he clearly told, after once he's stabilized, he told that he got some insect like mosquito bites or something. After that, he had a problem. So we thought it's Indian tick typhus, but we don't have any diagnostic confirmation.
Sir, mostly this patient fever with the rash of so many days duration. అదే అందుకే డ్యూరేషన్ అడుగుతుంది. 16th రోజు వచ్చింది,
అవును సార్,
ఫీవర్ స్టార్ట్ అయింది. 23rd రోజు ఇంకా హై గ్రేడ్ ఫీవర్ ఉంది, మీ దగ్గర అడ్మిట్ అయింది.
సార్ ఇక్కడ ఏంటంటే ఫ్యూ నెగటివ్ ఫైండింగ్స్. వాట్ ఐ కెన్ సే దట్ డెంగ్యూ ఫీవర్ లో యూజువల్ గా ర్యాష్ వచ్చిన తర్వాత, ఫీవర్ వచ్చిన తర్వాత ఆర్గాన్ ఇన్వాల్వ్మెంట్ అయ్యే టైంకి ర్యాష్ తగ్గిపోతుంది. ఇక్కడ ఏంటంటే ఫీవర్ ర్యాష్ కంటిన్యూస్ గా నడుస్తూనే ఉన్నాయి ఆయనకి. దట్ ఈస్ వన్ థింగ్.
మలేరియా we will have a diagnostic thing. ఇది మన if you do parasite V and F చేస్తే it's a very good sensitivity and specificity ఉంటది, కాబట్టి we can rule out malaria.
మలేరియా రూల్ అవుట్ చేశాం సార్,
మలేరియా రూల్ అవుట్ చేశారు. డెంగ్యూ, లెప్టోపై ఎట్లాగో ఇన్వెస్టిగేషన్స్ చేశారు
సార్.
ఎలివేటెడ్ అండ్ LDH ఇవన్నీ కూడా కొంచెం హిమోలైసిస్ కూడా కాంపోనెంట్ ఉంది. సార్ ఇది యాంటీబయాటిక్స్ తో రెస్పాన్స్ అయింది అని అంటే పాసిబుల్లీ స్ట్రెప్టోకోకల్ ఇన్ఫెక్షన్ ఆల్సో ఈజ్ ఎ పాసిబిలిటీ. ఇట్లానే ప్రెజెంట్ చేస్తుంది యూజువల్లీ, అండ్ విత్ లాట్ ఆఫ్ స్కిన్ ఇన్ఫెక్షన్స్.
But
And
skin is not
they
infected, sir. Here, skin is not infected. It's only rash. There is not.
స్కిన్ మేనిఫెస్టేషన్ ఇన్ఫెక్షన్
Sir.
స్కిన్ మేనిఫెస్టేషన్స్ తోని ఇట్లానే ర్యాష్ అండ్ విచ్ యూజువల్లీ విల్ బి pan sensitive organism బట్ యూజువల్లీ ఇట్ ప్రెజెంట్స్ లైక్ ఎ వెరీ విరులెంట్ అంటే పేషెంట్ కి మల్టీ ఆర్గన్ ఫెయిల్యూర్ అట్లా ప్రెజెంట్ చేసే అవకాశం ఉంటుంది ఒకటి. ఇంకా ఐ థింక్ మిగిలిన ఎక్కడ కూడా ఇన్ఫెక్షన్స్ లేవు కదా సార్, అంటే సిటీ అబ్డమిన్ కానీ చెస్ట్
అల్ట్రాసౌండ్, సిటీ అబ్డమన్, సిటీ చెస్ట్ అన్ని చేసామండి.
ఓకే సార్.
What is the biopsy report?
Biopsy report is inflammatory vasculitis.
ఏఎన్ఏ ఇవన్నీ నెగటివ్ కదా సార్?
ఇదండి సార్
ANA.
vasculitis picture negative. ANA profile negative.
ఇంకా ఇంకేమున్నాయి సార్ ఇంకా మనం చేయాల్సినవి ఏమి లేవు. అంటే లైక్ వేర్ లుకింగ్ ఎట్ న్యూర్ లైక్ జికా వైరస్ ఇట్లా యూజువల్లీ ఇంత ప్రెజెంటేషన్ ఉండదు, అది కూడా వైరల్. అండ్ ఎనీ క్లూస్ సార్, డేవిడ్ సార్ ఆర్ శ్రీనివాస్, రాణి మేడం?
Usually, even nowadays, even quacks, that means RMPs are also starting doxycycline, no?
Doxy, RMPs are putting Javicept.
Javicept, na? How this patient missed doxycycline?
Sir?
How this patient missed doxycycline outside?
అదే అర్థం కాదు. ఫస్ట్ టైం నుంచి దే ఆర్ థింకింగ్ దట్ ఇట్ ఈస్ ఫీవర్ విత్ ర్యాష్. దే థాట్ ఇట్ ఈస్ డెంగ్యూ అండ్ దే గివెన్ స్టెరాయిడ్స్.
Steroids.
ఫస్ట్ డే నుంచి he got steroids. We stopped steroids after coming to our hospital.
Okay.
But on steroids also patient is having fever, yes sir?
Yes sir. Yeah.
అంటే సేమ్ ఇలాగే ఇప్పుడు ఆల్రెడీ ఒక పేషెంట్ వెంటిలేటర్ మీద మలేరియా అనుకొని ట్రీట్ చేశారు.
సార్
అదే ఒక పేషెంట్ ఆల్రెడీ మలేరియా అనుకొని ఆల్రెడీ డయాగ్నోసిస్ పాజిటివ్ వచ్చి ట్రీట్ చేశారు. మల్టీ ఆర్గాన్కి వెళ్ళిపోయింది. పారాసైట్ లోడ్ చూడలేదు, బట్ వచ్చారు ట్రీట్మెంట్తో. రీనల్ ఫెయిల్యూర్ వచ్చింది, డయాలసిస్. అప్పుడు తర్వాత చూస్తే స్క్రబ్ పాజిటివ్ వచ్చింది. డాక్సీ ఆన్ వెంటిలేటర్ నౌ ఇంప్రూవ్ అవుతుంది. కానీ ఏంటంటే దట్ ఫెలో పేరు బజ్జీ బస్సు ఏదో ఉంది, ఒరిస్సా పేరు బజ్జీ సహ్వా. ఐ థింక్ ఇఫ్ సంబడి ఈస్ ఫ్రమ్ అవర్ మోహన్ రావు ఉన్నట్టున్నాడు అందులో, బెడ్ నెంబర్ 7. అదే కదా మోహన్ రావు?
సరే సార్.
సో అయితే నా విషయం ఏంటంటే మెయిన్గా ఫాల్స్ పాజిటివ్లు కొన్ని ఒకదానికొకటి కాంబినేషన్ అవి ఎట్లా సార్?
దేనికి సార్ ఫాల్స్ పాజిటివ్?
Only, rule out false positive test.
అమ్మో కష్టం. ఎక్స్క్లూజివ్ గా ఎలా చెప్తాం సార్? అన్ని
సార్ బేసికల్లీ మనకు మలేరియా ఏం చేశారు సార్? పారాసైట్ VNF
పాజిటివ్ వచ్చిందని చెప్పి చూపించారు వాళ్ళు అక్కడ ఒరిస్సాలో. అది పాజిటివ్
మలేరియా. ఓకే, మలేరియా విత్ మల్టీ ఆర్గన్ ఫెయిల్యూర్ ఉండదు సార్. ఆ స్క్రబ్ లో ఎస్కార్ ఏమని చూసారా సార్?
ఎస్కార్ లేదు, బట్ ఓన్లీ థింగ్ ఈజ్ మీరు అన్నట్టుగా స్క్రబ్ లో కూడా చాలా మందిని మల్టీ ఆర్గాన్స్ చూసాం సార్.
అవును సార్, అవునండి,
చూస్తాం సార్. ఈవెన్ షాక్ VC, షాక్ మల్టీ ఆర్గన్ ఫెయిల్యూర్. ఒకటి ఏంటంటే ఐదర్ యూ హ్యావ్ టు సీ ఎస్కార్. వీల్ ఫిలిక్స్ అయితే ఫాల్స్ పాజిటివ్ ఉంటుంది సార్. సో ఉండొచ్చు అదే సార్.
సార్ మలేరియా ఫాల్స్ పాజిటివ్స్ రిలేటివ్ గా తక్కువ సార్, బికాస్ దట్ వాట్ ఎవర్ ద ర్యాపిడ్ టెస్ట్ వీఆర్ డూయింగ్ ఇట్స్ వెరీ మచ్ అథెంటికేటెడ్ సార్.
అర్థమైంది సార్. ఐఎమ్ నాట్ టాకింగ్ అబౌట్ మలేరియా ఫాల్స్ పాజిటివ్, ఐఎమ్ టాకింగ్ అబౌట్ అదర్ థింగ్స్. ఫర్ ఎగ్జాంపుల్
sir, whatever it is sir, if the patient is not improving with this masala treatment for 5 days, we are missing that may not be the last slide is that only when that diagnosis is not correct, whatever we are dealing is not correct. 5 to 7 days should be under our control without treatment.
Sir, lepto aina scrub aina other streptococcal infection aina ivanni kuda they will penicillins plus doxy పెట్టేస్తే సరిపోతుంది సార్. యాక్చువల్లీ
కాంబినేషన్ ఆఫ్ డెంగ్యూ విత్ స్క్రబ్ కూడా వచ్చాయి సార్.
అవును సార్, అవును.
మన ఎంప్లాయ్ సతీష్ ఉండేవాడు కదా, మోర్టన్ లాట్ ఆఫ్ కాంబినేషన్స్ అండ్ ఫాల్స్ అది డిఫికల్ట్ అవుతుంది సార్. అంటే ఏది కరెక్ట్‌గా డౌట్ వచ్చి ఇప్పుడు మీరు ఫర్ ఎగ్జాంపుల్ డెంగ్యూ అయితే మనం ఏ మెడిసిన్ ఇస్తాము? మీరు అన్నట్టుగా స్టీరాయిడ్ ఆ కాంబినేషన్స్‌లో ఇబ్బంది వస్తుంది. అవి ఎట్లా అన్ని కొన్ని ఏవి ఫాల్స్ పాజిటివ్ వచ్చే అవకాశం ఉంది. ఎందుకంటే కోవిడ్‌లో కూడాను ఫాల్స్ పాజిటివ్ వస్తున్నాయి అంటున్నారు సార్. అందుకోసం చెప్పండి సతీష్ గారు.
The false positives are very common with lepto, sir. లెప్టో ఇప్పుడు మనం చదివిన ఈ డిసీజ్ లిస్ట్ లో ఫాల్స్ పాజిటివ్స్ వెరీ కామన్ ఇన్ లెప్టో, బట్ ద అదర్ సైడ్ ఇస్ వీ మైట్ మిస్ ఎ డయాగ్నోసిస్ పాజిటివిటీ. సమ్ టైమ్స్ వీ మే నాట్ హ్యావ్ ఎ డయాగ్నోసిస్ రెస్ట్ ఆఫ్ ద డిసీజెస్ లో. We presume that it is dengue, looking at the symptomatology and findings, we presume it can be scrub. But lepto ఏంటంటే చేయగానే ఐజిఎం పాజిటివ్ వచ్చినంత మాత్రాన మనకి కాకపోవచ్చు. స్టిల్ వీ హ్యావ్ టు ఓపెన్ అవర్ మైండ్. ఇట్ మే నాట్ బి లెప్టో ఈవెన్ దో ఇట్ ఇస్ test is positive. The otherwise
Even you will get scrub typhus false positive.
Scrub typhus we miss the diagnosis. False positives తక్కువ, but we may not get the diagnosis.
లేదు సార్, స్క్రబ్ టైఫస్ ఫాల్స్ పాజిటివ్స్ వస్తున్నాయి సార్ కొన్ని.
వస్తున్నాయి సార్. ఇప్పుడు we have
ఎందుకు
seen.
అంటున్నానంటే ఐ డోంట్ నో ద ఎగ్జాక్ట్లీ. ఐ వాంట్ రియల్లీ ఆస్క్ డేవిడ్, మీ దగ్గర ఎన్ని వస్తున్నాయి, అలాగే రాణి మీ దగ్గర ఎన్ని వస్తున్నాయి? ఎందుకంటే స్క్రబ్ టైఫస్ మెకానిజం ఆఫ్ అండర్స్టాండింగ్, ఎందుకంటే ఇట్ ఇస్ రికెట్సియల్ ఇన్ఫెక్షన్ కదా యాక్చువల్ గా,
అవును సార్.
బ్యాక్టీరియా వల్ల వస్తుంది కదా. సో అది ల్యాబ్ లో ఏ విధంగా టెస్ట్ చేసి ఇస్తున్నారు స్క్రబ్ టైఫస్?
సార్ లాస్ట్ అర్థం అవ్వలేదు ల్యాబ్ లో.
What is the mechanism they are identifying for subtypes and giving you?
Once you got a false positive, if you feel that it is false positive, you have to do that wheel Felix test, I think, for subtypes.
వీల్ ఫిలిక్స్ లోనే ఫాల్స్ పాజిటివిటీ చాలా ఎక్కువ ఉంది.
Then what test you will do? Is for any RT-PCR?
We are not doing it. అంటే basically it is not done for this ఇది చేయరు. I think they can do I think antibody levels చూడొచ్చు సార్, బట్ అట్లీస్ట్ బట్ అగైన్ ఇన్ ద సెకండ్ వీక్ లేనే కదా అది.
సతీష్ గారు, మీ దగ్గర స్క్రబ్ టైఫస్ పాజిటివ్ అని వస్తుంది కదా, ఏ టెస్ట్ ద్వారా మనకు వస్తుంది స్క్రబ్ టైఫస్ పాజిటివ్ అని? ఏం చేస్తున్నారు టెస్ట్ వాళ్ళు?
చెప్తున్నాను సార్, ఒక్క నిమిషం.
Only they do ELISA.
ICM ELISA
only do.
దాని స్పెసిసిటీ సెన్సిటివిటీ ఎంత సార్?
చెప్తున్నాను సార్. So indirect fluorescent antibody is the gold standard test to identify the scrub typhus. Highly specific, highly sensitive.
ఏంటి సార్ అది?
Indirect fluorescent antibody test, rickets IFA test, routinely we do ICM ELISA.
మనం చేసేది అదేనా అందరి
మనం చేసేది ఎలిసా టెస్ట్ సార్. మనం చేసేది యాక్చువల్ గా ఏంటంటే యాంటీబాడీస్ చేయాలి ఐజిఎం, అది సెకండ్ వీక్ లో పాజిటివ్ ఉంటది.
అవును సార్.
అండ్ లెప్టోకి చేయాలి అంటే ఈవెన్ ఇన్ ఫస్ట్ వీక్ యూ కెన్ డూ బ్లడ్ ఆర్ యూరిన్ డార్క్ ఎగ్జామినేషన్ సార్, డార్క్ ఫీల్డ్ ఎగ్జామినేషన్.
లెప్టోకి మైక్రోస్కోపిక్ అగ్లూటినేషన్ టెస్ట్ ఇస్ ద గోల్డ్
ఇంటిబేషన్
యూరిన్ ని మైక్రోస్కోపీ డార్క్ ఫీల్డ్ ఎగ్జామినేషన్ చేయొచ్చు ఫస్ట్ వీక్ లో, ఫస్ట్ ఎండ్ ఆఫ్ ద ఫస్ట్ వీక్. కానీ యాంటీబాడీస్ కి రావాలి అంటే కనుక మనం వీ హావ్ టు డూ
10 days వెయిట్ చేయాలి.
సెకండ్ వీక్ లో చేయాలి ఐజిఎం.
గో సార్. ఐజిఎం యాంటీబాడీ by enzyme based dot immunoassay sensitivity is 30% at day 3, 100% at day 10.
సో అది సెకండ్ వీక్ చేయాలి. అందుకనే మనకి మంచి మైక్రోబయాలజిస్ట్ ఉంటే వీ కెన్ డూ డార్క్ ఫీల్డ్ ఎగ్జామినేషన్.
We have seen few patients coming from Odisha. They are having reports with typhoid positive, malaria positive, dengue, NS1 positive, all these things positive. So once you do tests here, all are negative. So can we continue this malaria treatment, or anyway this all antibiotics most cover typhoid?
Sir, malaria treatment is a standard therapy for almost 1 week. So అది ఇచ్చేసి వదిలేసేయడమే సార్.
అన్ని 5 to 7 days.
It can be it can be positive even. You see, you are doing an antigen test. So antigen test it can be positive for months also sometimes. So you give a appropriate therapy and leave it.
Will you
And
continue
manage
the
complications.
treatment for 1 week, or if your test QBC or other test negative, can you stop that malaria treatment?
No, sir. No, sir. See, once you are antigen testing parasite V and F is positive, you have to give a treatment. Don't give empiric treatment, as Satish sir already mentioned.
No, not
Don't give
empiric. If they
empiric.
get positive.
Once it is positive, it is positive, sir.
Is there any false positive in malaria, Satish?
No.
ఒకటి ఏంటంటే సార్ ఇప్పుడు there are few areas like ఇప్పుడు శ్రీకాకుళం కానీ ఆదిలాబాద్ డిస్ట్రిక్ట్ కానీ where there is a malaria is an endemic thing. It's continuously endemic. So endemic ఉన్నప్పుడు ఏమవుతుందని అంటే you will have infection అంటే ఒక సబ్ క్లినికల్ టైప్ లా మినిమల్ ఎక్స్పోజర్ నుండి ఇన్ఫెక్షన్ వస్తూ ఉంటుంది, వాళ్ళకి కంటిన్యూస్ గా వస్తుంటాయి. సో వాళ్ళకి యాంటీజెన్స్ అప్పుడప్పుడు క్యాపిలరీలో ఫిక్స్ అయి ఉంటాయి సార్, అప్పుడు పాజిటివ్ రావచ్చు. బట్ ఇఫ్ హీ హాజ్ హ్యావింగ్ ఎ ఫీవర్ విత్ ఎ పాజిటివ్ అంటే డెఫినెట్ గా ట్రీట్ చేయడం.
Andra sir, you are silent.
Yeah. Good morning to everyone. Really, it is very challenging to treat a tropical infections by intensivist because, as David mentioned before, most of we are working in a tertiary care hospital. So there is a lot of change coming to our hospital because from RMP level onwards, they will get the treatment. So masala treatment, what Satish has told is if you want to treat properly, we have to first improve our lab, quality of lab and everything. When we are working in previously that CMs will if the malaria comes positive, then only they will give the anti-malarial treatment. For that, they will do the 3 smears, 3 days continuously smear. They're very confident on reporting for the labs and the rest of this scrub typhus infections, everything. So without improving our lab, by seeing symptomatology by giving the treatment is okay. But by the time comes to us, it will be delayed. So it is very difficult. By the time we have to give the all cover the scrub, leptospira and malaria to some extent to combat the sepsis and septic shock associated with leptospira. Sir.
No,
Sir,
what
as
are false positives? See, they are looking at a malaria parasite slides 3 times. So that means there is a chance of that they will miss it in first slide. That's why they're doing 3 times.
No, sir. If first comes positive, then they won't do second and third samples.
I understand. So that means they are doing 3 times to confirm whether it's there or not there.
Yes, sir. Every 12th hour they will send the blood sample. Sometimes
No, that means there is a chance of missing malaria most of the times in first or second. That's what.
Yes, sir.
So are we in that case? Are we sending 3 times for malaria testing? Anybody?
Sir, we are talking 2 things, sir. He's telling about microscopy.
Microscopy.
Okay. So microscopy.
Which is gold standard.
Yes, you can do a thick smear, thin smear, QBC. Now, if you do no need to do this all thick and thin smears are now. What we do is we are directly doing the strip test, sir. Antigen testing, parasite V and F. There's no chance of missing, sir. So one test is enough.
Yeah, as Satish sir said, once you
So
start
in the
this
CNC
triathlon
means the old technology.
Yes, sir. Still,
No.
still people are not. Still, we are doing smear test
Sir,
only.
it is a gold standard test. It is not old or new. No, Satish mentioned one thing. Once
Sir.
you start the treatment with ceftriaxone and doxycycline, after 5 days, patient is not responding. So you can rule out parasitic infections. That's correct, no?
We have to rethink our diagnosis.
Yeah, some other diagnosis.
Yeah.
Sir,
What is
miss
the role of parasitic load?
Sir.
Malaria?
No role, sir.
No role?
No role.
Can you ask to see the parasitic index or parasitic load? Because when I was working in Chennai, Dr. Babu
Yes.
Abram always asked to see the load, parasitic load, because once the parasitic load is very high, we have to do dialysis to remove the load.
Plasma
Otherwise,
exchange
these
we used
patients
to
may
do.
go
Plasma
into
exchange,
renal
sir.
failure. Huh?
Plasma exchange we used to do if it is
Yeah,
more than
yeah.
10.
Correct.
But removed, sir. That is recommendation is removed from guidelines.
Sir.
Why?
Malaria law points that what we are discussing. Microscopy, thick smear, and we for parasite detection, thin smear is for species identification. Okay. Hello?
Sir, please.
David, Anna, inpistunda na voice break vastundi.
Yes, sir.
చెప్పండి.
So, malarial antigen lo immunochromatographic test based on the antibodies to the malarial antigen like histidine-rich protein. Adi mana chesedi ade. Lactate dehydrogenase antigen immunochromatography is the level 1A evidence to identify the both bug and the species. And also there is a we are looking into Plasmodium aldolase levels. Highly specific and highly sensitive, more than 95%. If 2 rapid diagnostic tests are negative, we can rule out malaria if 2 consecutive rapid diagnostic tests are negative. So that's the importance of the test. What Srinivas sir told that that stick parachecker stick test comes under the same category. It is RDT only.
If patient comes with fever
Yes, sir.
with rash, can we start ceftriaxone and doxy empirically?
Anna?
Fever with thrombocytopenia rash syndrome.
No.
Then we start this ceftriaxone and doxycycline empirically.
The ISCCM document also has given the same, sir. The cocktail as ceftriaxone and doxycycline. Usually, some of them say no, we don't give these antibiotics, but practically everybody will give these antibiotics. One is patient having a fever, thinking of a bacterial infection. Also, one ceftriaxone is started, and second thing is we may think that scrub possibility, and we start on a doxy. And the ceftriaxone also will cover for even leptospirosis also. So this combination is a good combination, unless you suspect some community acquired some resistant organisms.
Now, what is the dose of doxy?
100 milligrams twice daily for 5 days.
Now they are telling 200 milligrams BD.
That's okay. Some people are telling that, but it's not like recommendations wise. It's only 100 milligrams twice daily.
Okay.
So, Srinivas sir, so anything to discuss, sir? Last lo oka maatladali nenu before we are signing off.
Okay, sir.
Mohan sir.
Sir, మాట్లాడండి సార్.
This is 2 patients, sir. Very, very tough patients. One is young fellow, 28 years, and other is 78 years old man. Both are having severe rhabdomyolysis. We are trying to figure out the reason for rhabdomyolysis. Still not able to find out on day 6 of admission. We are given dialysis. We have IgM positive. That is one hope that we got IgM positive, but I never seen any patient in literature. Also, there is 1 or 2 case presentations dengue with rhabdomyolysis, and MRI is showing some MERS-like feature. They told that is some encephalopathy, minimal encephalopathy, reversible in the splenium anta ento adi diagnosis. So it is like equal to MRI finding of encephalopathy. So ఈ పేషెంట్లు రెండు టఫ్ గా ఉన్నాయి అంటే ఇట్స్ నైస్ 2 పేషెంట్స్ ఫర్ డిస్కషన్.
సిపికే ఎంత ఉంది సార్?
సార్
ఎంత ఉంది రాబ్డోమైలిసిస్ లోడ్?
ఇద్దరు రాబ్డోమైలిసిస్, ఇద్దరు రేనల్ షట్ డౌన్, ఇప్పుడు స్టిల్ ఆన్ డయాలిసిస్. 3 lakhs
డయాగ్నోసిస్ ఏంటి సార్ ఇంతకి పేషెంట్ కి?
సార్ ఈటియాలజీ లేదు సార్ నా దగ్గర, ఈటియాలజికల్ డయాగ్నోస్ లేదు.
డెంగ్యూ ఈ సార్
ఒక్క యంగ్ ఫెలోకి మట్టుకు దేర్ ఆర్ కాంట్రవర్షియల్ ఇష్యూస్. వన్ ఫ్రమ్ ద పేషెంట్ పాయింట్ ఆఫ్ వ్యూ, 2 days of 1 day of loose stools and diarrhea, having a cake injection. ఫ్యామిలీ 4 members కి అడ్మిట్ అయ్యారు. ఈ నెమోని ఆల్టర్డ్ సెన్సోరియం వచ్చింది. Then found that his creatinine and urea are high and platelet count were around 1 lakh, NS1 negative. So
recent
elderly patients are 78 years.
Elderly patient found lying down in the floor in the bathroom. They broke open the key and brought him onto the bed. His sensorium is preserved but not able to move his limbs actively. Maybe post ictal ఆరావా సీజర్ వచ్చి పడిపోయాడా తెలియదు.
సో ఇండోర్ నుంచి ఉంది సార్ ఇది రాబ్డోమైలిసిస్.
ఆయనకి there is a reason we can say that he is having metformin, he is already on statins, he is having ACE inhibitor and ARBs, maybe intrinsic nephrotoxicity on and above there is a rhabdomyolysis inducing medication
అన్ని ఉన్నాయి కదా సార్?
ఉన్నాయి కాబట్టి పాసిబిలిటీ ఉంది ఆయనకి. But it is not a new thing. He is getting statins for the last 10 years. He is getting
CPK ఎంత ఉంది సార్?
CPK is 2,75,000 on the first attempt.
2 lakhs
2,75,000 and the young boy CPK is 3,80,000.
అంత వస్తుందా?
Did you rule out any biopsy?
మజిల్ బయాప్సీ చేశాను, పంపించాను. MRI చేయించాము, నెర్వ్ కండక్షన్ స్టడీస్ చేసాము, ప్రాక్సిమల్ న్యూరోపతి ఉంది. ఇట్స్ ఆల్ డెంగ్యూ రిలేటెడ్ మయోపతి. IgM పాజిటివ్, అది ఒక్కటే పాజిటివ్ ఆ కుర్రాడికి.
ఇంత రాబ్డోమైలిసిస్
అండ్ ఇట్ ఈస్ ఆన్గోయింగ్ రాబ్డోమైలిసిస్. We could not stop it. Like day 1
having any seizures?
No, altered sensorium ఉంది అంతే.
He's conscious.
He's obeying commands.
Okay.
మంచి కేసులు సార్. ఇప్పుడు మనం కొంచెం నేను ఫుల్ డీటెయిల్ పెడతాను. నేను
లెఫ్ట్ నెగటివ్ ఉంది కదా సార్?
ఏదండి?
లెఫ్ట్ నెగటివ్ కదా?
లెఫ్ట్ నెగటివ్.
Right, sir. If there are no questions, we will close today.
David sir.
Sir.
ఇంకా 2 minutes టైం ఉంది. కెన్ ఐ జస్ట్ గివ్ వన్ టాక్?
ప్లీజ్ సార్.
ఏం లేదు, టాక్ గురించి కాదు, రిక్వెస్ట్. ఐ రిక్వెస్ట్ ఆల్ అవర్ పీపుల్ టు ఎంకరేజ్ రిజిస్ట్రేషన్స్ ఫర్ అల్ట్రాసౌండ్ వర్క్షాప్ అండ్ మేబీ వీ మే కండక్ట్ రిఫ్లెక్ట్. సో ఐ జస్ట్ వాంట్, బికాస్ ఓన్లీ 5 vacancies are there still, because first we told we will only take for the interested candidates. So still 5 vacancies are there. I request everyone to encourage ultrasound workshop for registrations, because we have only 2 days time and we have a best faculty. Thank you, sir.
Right, sir. Thank you very much, Dr. Satish, for your